Dear colleagues, let me introduce my PhD topic, which is the use of autogenous tooth bone grafts in alveolar ridge preservation. My name is Eleonóra Sólyom, and I am from the Department of Periodontology. My mission is to change the mindset of the tooth extraction. I think none of the extraction sockets should be left unpreserved. Our aim is to search for the best graft material and for the best technique for alveolar ridge preservation, and to reach this goal, we have these three projects. But briefly, some words about the alveolar ridge preservation. We know that every patient from our own will lose at least one permanent tooth during their lifetime, and without an immediate intervention, in the first year, the width of the alveolar ridge can be reduced by 50%, and this deficiency of the facial bone anatomy is a critical causative factor for implant failures and also has a negative impact on aesthetic implant complications. But with an immediate surgical intervention with alveolar ridge preservation, we can reduce these negative horizontal bone changes by 60 to 40%. So, in the first project, we are investigating a novel graft material called autogenous tooth bone graft. Our second project is a comparison of novel RP techniques, and the third project is a comparison of different graft materials. So, the title of our first meta-analysis is The Use of Autogenous Tooth Bone Grafts is a Safe and Predictable Way for Alveolar Ridge Preservation. We finished the article writing with my supervisors, and we are waiting for our SMS to send it to the internal review. So, our clinical question: is autogenous tooth bone graft an effective way for alveolar ridge preservation? And the primary outcome is the changes in ridge width in millimeter, and the secondary outcomes are the histological outcomes. Our hypothesis that ATB can be as effective as other bone graft materials in preserving the width of the alveolar ridge, and it has also a greater graft remodeling capacity compared to other bone graft materials. We did the systematic search in 4 databases, and after the selection process, we have 12 eligible articles for the qualitative analysis and 8 for the quantitative one. So our results. Our primary outcome is the pooled mean of ridge width changes in millimeter. We had to make a subgroup analysis according to the measurement methods, because some of the articles measure the alveolar ridge width at the ridge, and some of the articles measure the alveolar ridge 1 millimeter apically from the crest. The clinical importance: we know if the lower the ridge width changes, then the wider the alveolar ridge, and then the more predictable and safer the implant placement. The effect size is 0.72 millimeters. Without alveolar ridge preservation, it would be 2.6 to 4.5 millimeters, and with xenografts, which tend to be the gold standard in the dental field, it would be almost 2 millimeters. So our first hypothesis that ATB can be as effective as other bone grafting materials in preserving the width of the alveolar ridge is accepted. Our secondary outcomes are the histological outcomes. There are lots of companies with lots of protocols to gain these autogenous tooth bone grafts, and it's hard to differentiate between these materials. But we made a subgroup analysis according to the demineralization process. The first is the undemineralized, the second one is the partially demineralized, and the third is the demineralized dentin matrix. But the mechanical and biological differences between these 3 graft materials is not quite clear. So you will see an increased significant heterogeneity due to these demineralization processes. But how we evaluate these histological outcomes? After the healing processes, we are making a flap, take the trephine drilling to take the core biopsy, and on the histological sample, we can differentiate between the residual graft, the newly formed bone, and the soft tissue or connective tissue proportion. So the first one is the pooled mean of residual graft proportion. We know if the lower the residual graft proportion, then the higher the bone implant contact and the more predictable the implant placement. Because these encapsulated residual grafts, which are usually at the coronal part of the alveolar ridge, they can jeopardize the bone implant contact. The effect size was 11.61%, and with the xenograft it would be according to 30%. So our second hypothesis that ATB has a greater graft remodeling capacity compared to other particulate graft materials is also accepted. The second one is the pooled mean of newly formed bone proportion. It's logical if the higher the newly formed bone proportion, then the higher the bone implant contact, and of course more predictable the implant placement. The overall effect size is 40.23%, and with the xenografts it would be above 20%. And there is a statistical significant difference between the demineralized and the partially demineralized grafts. So our second hypothesis is also accepted. So to summarize, the use of autogenous tooth bone grafts is a safe and predictable way for alveolar preservation, but there is a significant heterogeneity in the preparation process, and we have a left configuration, its exact influence on the graft material and also on the healing processes. The used tooth material, because some of the articles used only the root part, the other articles use the root plus the crown part as well, seems not affect the mentioned parameters. We suggest a more detailed inclusion criteria, RCTs with different processing methods, a detailed randomization procedures, and of course a pre-specified analysis plan for the further in vitro and in vivo clinical studies. Our second project is the clinical, radiographical, histological evaluation and blood flow analysis of hard and soft tissue changes following alveolar ridge preservation. We aim to make a three-armed randomized clinical trial. In the first arm is the socket seal group. When we extract the tooth and we won't feel anything to the extraction socket, we harvest some soft tissue from the hard palate and suture it above the extraction socket. The second one is the extraction site development plus socket seal group. When we extract the tooth and we reconstruct the buccal bony wall with the xenogenic membrane, we fix the xenogenic membrane to the buccal side with titanium fins, and we also harvest some soft tissue from the hard palate and suture it above the extraction socket. And the third one is the XSD plus ATB plus socket seal group. When we extract the tooth, we clean it, we grind it, we fill it back to the extraction socket. After a demineralization procedure, we also reconstruct the buccal bony wall with the xenogenic membrane, and we also harvest some soft tissue from the hard plate. So our question that are these novel techniques can be a predictable way for alveolar ridge preservation. And the outcome, the primary outcome, is the changes in ridge width after 6 months, which is measured intraoperatively. Our hypothesis that XSD and XSD plus ATB groups are expected to have less pronounced horizontal width losses, and XSD group is expected to produce the highest graft turnover. And the clinical implication, of course, is to evaluate these novel techniques for RP. So the primary outcome is the intraoperative assessment of alveolar ridge width changes by linear measurement with a periodontal probe during the procedure and after 6 months. We have several secondary outcomes as well. We have the ethical approval so far for our randomized clinical trial, and we are in the international registration phase. And the third project is the histomorphometric evaluation of different alveolar ridge preservation techniques. What we know about the graft material which are used for the alveolar ridge preservation, they can be particulate and non-particulate ones. The advantages of the particulate graft materials that they are really easy to use, and they also have the space maintaining effect, but the residual particles can be up to 62%, and as I mentioned before, these particles can jeopardize the bone implant contact. The non-particulate ones, they have mostly less residual graft proportion, but the disadvantage is that they also have a lower space maintenance effect. So our aim is to investigate whether the same alveolar ridge width and the greater graft turnover can be achieved with the non-particulate graft materials. Our question that can alveolar ridge preservation with non-particulate graft materials be as effective as with the particulate ones? In the intervention group, we have 5 interventions. They are all from the non-particulate graft materials, and we would like to compare it to the particulate graft materials. The primary outcome is a percentage of newly formed bone. Our hypothesis that with the use of non-particulated grafts, a larger amount of newly formed bone can be detected. We did the systematic search in 4 databases, and after the selection process, we have 44 eligible articles for the qualitative analysis. And we are now at the data extraction part. I hope we can finish it this week. So to reach our goal, to search for the best graft material and technique for our ridge preservation, we have these 3 ongoing projects. And I would like to thank you for your kind attention with this quote from Professor Lars Hammarström, who invented endogain in 1996. And once he was interviewed and asked how is he feeling about this great invention, and he told that I have built many theories in my life. I am happy that this one worked. Thank you.
Thank you very much for your presentation. Coming back to another presentation from before where we heard about the benefits of PRP, and now looking at your presentation, and since you're the socket expert here, do you think there's also a benefit for PRP then in filling the socket with PRP maybe? Or is there something already like this existing in dentistry?
Thank you for your question. Of course, there are lots of randomized clinical trials about the efficacy of PRP and also the efficacy of PRF. And in our third project, our aim is to investigate if we can use PRP and PRF and all the autogenous materials in preserving the ridge width, and also to gain a greater graft remodeling capacity compared to the particulate ones. Because according to our clinical findings, usually PRF don't have the space maintenance effect, and that's why we have a little over ridge width loss after the healing process.
Well, my question is, actually this is a kind of open question, as I understand that with this autologous tooth graft, I mean, the results are variable, probably depending on the preparation. Am I right? So do you address this in your meta-analysis, actually?
So the question was that they are really...
The heterogeneity of the studies, yeah. I mean the results, because some of them, in some hands, it was effective, including your hands, I mean the departmental hands, and some others were not. And there were previous discussions on this, that this may be due to the different kind of preparations.
Of course, and these graft materials is only invented and started to use for human studies in 2011. So I think we need more randomized clinical trials. We try to collect all the data, so we also included some case series as well. And of course, there is a huge and increased heterogeneity in this topic, but I think in the dental field, all in all, we have almost every article is a huge heterogeneity when we try to evaluate them. And this is because the lack of randomization procedures sometimes, and the lack of blinding as well. So I think not only the graft materials is very diverse, as you mentioned, this is one thing, but the other thing is we need a more detailed inclusion and exclusion criteria to be written in the RCTs. So I think this is the other issue. And it's a big question if we can pool all these ATB together, so to call it autogenous tooth bone graft and just to refer it in this phase, or we should differentiate between the graft materials as partially mineralized and demineralized graft materials. So that's a big question. This is the first meta-analysis, so we hope that with further RCTs there will be more data, and then it will be more accurate as well. Thank you.
In your first topic, there was a study, Yoshi and co-workers, 2016. It was a really differing study. And I just wanted to ask, what's the background of this really differing result?
Yeah, thank you for your question. This is one thing that I mentioned to Professor Varga, that the defects, so the inclusion criteria is not quite clear in every study. And in this article, they used only the 4-volt bony defect. And if we have more voles, more of our bony voles, then the blood supply is better and the healing is probably better in these cases. So that's why this study is an outliner, and we also discussed this in our manuscript. Thank you.